And welcome to the John F. Kennedy Junior Forum here at the Institute of Politics. My name is Robert Fogel. I'm a junior at the college studying economics, and I'm one of the co-chairs of the John F. Kennedy Junior Forum Committee. Before we get started, please note that exit doors located on the park side and the JFK Street side of the forum. In the event of an emergency, please go to the exit closest to you and congregate in the JFK Park. Now, please take a moment to silence your cell phones and join me in welcoming Harvard Kennedy School graduate student Nana Efwa Afo-Manin.
Good evening, everyone. Welcome. It is my absolute pleasure to introduce Dr. Rochelle Walensky. Dr. Walensky served as the 19th Director of the Center of Disease Control and Prevention during the historic COVID pandemic and global public health crisis. She received her BA in biochemistry and molecular biology at Washington University, St. Louis, her MD at Johns Hopkins, and her MPH here at Harvard School of Public Health. Yeah, give her flowers. She completed her internal medicine residency at Johns Hopkins Hospital and infectious disease fellowship at the Mass General Hospital, Brigham and Women's Hospital of Combined Program. Prior to her appointment at the CDC, she served as the chief of the Division of Infectious Diseases at Mass General Hospital and the professor of medicine at Harvard Medical School. Her clinical research in HIV and AIDS was instrumental in changing US HIV testing and immigration policy, promoting expanding funding for HIV-related research, treatment, and advocacy. And Dr. Walensky has been an active member of policy discussions at the WHO, UNAID, and the chair of the DHHS HIV Guidelines Committee. For me, she's truly the epitome of preparation meets opportunity. And her leadership during the COVID pandemic says it all. She was at Mass General Hospital, was hugely successful. During her tenure, she participated in nearly 100 press conferences, countless media appearances, and provided testimony at 17 congressional hearings. And that was before she went to the CDC. As a fellow physician and recovering ER doctor, I truly appreciate her commitment to transparent communication. Dr. Walensky created one of the CDC's most powerful initiatives yet, CDC Moving Forward, an effort towards timely action, clear, and accessible communication. This was the most positive impact for several frontline health providers. Indeed, Dr. Walensky was showing up in my inbox every single day. In the New York op-ed, Dr. Walensky wrote, "Public health work continues to be critically important and the challenge is just as complex. Yet I fear the despair from the pandemic is fading too quickly. From our memories, and maybe perhaps it's because it's too painful to recall a ravaged nation brought to its knees." Dr. Walensky shared how incredibly proud and grateful she was to have a supportive family and partner during her time at the CDC and throughout her career. She is married to Larsen Walensky, a physician scientist and pediatric oncologist at Boston Children's Hospital. When he's not saving lives, he's lifting her spirits, ordering groceries across state lines, and taking care of their 3 amazing children. On behalf of the frontline health workers, thank you, Dr. Walensky, for your service. We are honored to have you as a senior fellow at the Kennedy School's Women in Public Policy program. Interviewing Dr. Walensky is Roy E. Larsen Senior Lecturer in Public Policy and Management at HKS, Dr. Hannah Riley Bowles. Professor Bowles co-directed the HKS Center of Public Leadership and Women in Public Policy program. Her research focused on women's leadership advancement and the role of negotiation in educational and career advancement, including management of work-family conflict. Professor Bowles has involved in negotiation and conflict management for over 25 years and has a DBA from Harvard Business School and co-directs 2 executive programs for women and senior leadership. She's a woman who wears many vibrant hats, many publications, and one huge heart. I also want to warmly welcome the Women's Leadership Board and our entire community to this conversation, both in person and online. I would also like to acknowledge the chair of the Women Leadership Board, renowned business leader, Janice Bryan Howard, another personal role model of mine. I welcome Dr. Walensky and Professor Bowles to. Thank you very much.
Thank you. That was unsurprisingly coming from you, an exceptionally beautiful introduction and a wonderful setup for our conversation. Thank you so much. And pulling on some of the threads of the things that you highlighted, I would like to take you to this moment, January 2021. You're taking over as the head of the Center for Disease Control, the CDC. We are suffering in the United States 3,000 deaths per day. And to this point, it was just shocking, actually, to be reminded of that, 3,000 deaths per day. The agency that you're taking over is a scapegoat for this fear and anger in the nation about what is going on. And you have a workforce that is personally scared, or many of them, in any case, personally scared and demoralized by the situation that they're in. So why did you take this job?
What were you thinking? First of all, it's just a pleasure to be here, so thank you very much and for the beautiful introduction. I received a completely unexpected phone call. I received a phone call, I think it was November 9th, while I was literally gowned and gloved in a patient room, and my phone went off and I couldn't get it to stop. So I took off my gown and gloves, and it was my youngest son saying Biden won. And so we were excited as a family that we were going to enter a new era. 2 weeks later, I was at Mass General, doing what it was hard at Mass General at the time, and we were working really hard. Our beds were full. I think the morgue outside the hospital had since left, but there were some hard times. And I received a phone call from Ron Klain. I was not in my office at the time, and he left a message with a 202 area code. I knew the name, I Googled the name, and before I called him back, I made one phone call to my husband, and I said, Ron Klain called me, and Lauren, to his credit, because he knows his wife, said, don't say no. Whatever he asks, don't say no. I think he sort of knew that whatever he was going to ask, I was going to say, So he asked if I would consider running the CDC. It was not a job I anticipated. It was not a phone call I anticipated or ever applied for. And we had a lot of conversations in the ensuing weeks as the vetting happened. But I will tell you that sort of 2 simultaneous things went through my mind. One is, how could I ever possibly do this? I didn't tell very many people because I was being vetted. And it was confidential. But everybody had said, who I had talked to, it's going to be an impossible job. The agency, the morale is terrible. The agency has not done well so far in this pandemic, so how could I ever do this? And somebody is calling you at a time there are 3,000 deaths a day, And what I said in my nomination speech is, when you are the intensive care unit resident, you hold what's called the code beeper. And that code beeper goes off and you run. And so this was the nation coding, and I was holding the code beeper, and the answer was you run. So that was a little more powerful than the how could I ever do this? And I had amazing support from my family. And so I figured if somebody thought I could help, then I was going to be there to help.
That's beautiful. And I want to come back to this, also how your values as a doctor have guided you in difficult moments. But let me start first with the being put in this leadership role. How did you try to address the divisions and the demoralization? You were actually getting flack from within the center, like right from the beginning. And so what were some of the strategies that you used to, rebuild the integrity, the morale, the operational effectiveness of the agency?
Yeah, so some of the things I did intentionally because I thought they would boost morale, and some of them I actually did because they were the right things to do. They actually also boosted morale. So first thing to know is, while I had an apartment in Atlanta, I flew down to Atlanta as soon as I was sworn in. The first thing that they said is, but the government's closed. You're not allowed to be here. Certainly we had people at the CDC who were working in the labs, but there really was this effort to not bring people back. And when I was there, people came in. And so I tried to be there with some intermittent frequency, but doing all of that remotely was actually increasingly hard. One of the first things that I did was really try and meet people, and as you recall, the agency did not trust the administration, the prior administration. The agency did not trust, I think, the prior director. Perhaps I'm wrong, but I had to build trust and to have them know that I was going to listen to what they had to say, that they were going to present me science, I was going to ask questions, and that came over time. It's how they saw me operate, that I would lie on the highway for the right thing to do. Mm-hmm. They saw that over time. I did start meeting one-on-one with center directors. There were about 25 of them. Then I did what I call skip level meetings, meeting with division directors. There were probably about 120 of them, many of whom said to me they had never in their 30 years at CDC met with a director before. But I really wanted them to know that they could always, if there was distress, they could call me. I then also met with our country directors. We had country directors in 60 different countries, and you could see over time that tragedies happened in these countries, and we had people on the ground, including in Ukraine, including in Haiti, including in Ethiopia. And I didn't want my first phone call to these country directors be like, are your people okay? Are you safe? I wanted to have relationships with them first. So I did a lot of this outreach. One of the things that I did that I didn't necessarily expect would be such a morale boost was April 10th, I believe it was, of 2021, so just like 8 weeks after I had started, we declared racism a serious public health threat. It was perceived as bold. I was told I was the first one to make such a declaration for the agency, and yet it seemed like obvious that we needed to do it. And especially in that moment, as you recall, one of the things we were so focused on was getting vaccines into arms in an equitable way. And so while we were doing that work, it seemed only right that we would make this declaration. I'm really proud to say that over 200 departments of public health have followed suit since that time. So we were certainly not the first. There were others that were doing it, but there was a wave of people that were making that declaration. And what that did is it unified the agency, and they sort of recognized we were going to work together toward that mission. I said to the agency, and remember, these people were working really hard, again, scared for their own well-being and their own families, working overtime, and I said, every time we look, everywhere we look, we document a problem in inequities in the care we deliver, the prevention that we deliver. I'm done documenting the problem. Create solutions. Implement solutions, and let's talk about folate supplementation in Indian country. Let's talk about how we can have, and they may not all work, they probably won't all work, but we're going to learn something along the way rather than just documenting yet again that there are inequities. So I think those things, maybe one other, and that was these unsung hero calls that I made. So it became very clear to me in an agency of 12,000 people that it was going to be very hard to touch everybody. But it also became clear to me that there were people doing all sorts of work that I didn't even know they were doing or recognizing. We had people who rappelled out of helicopters to drop test kits onto cruise ships. So these people were working all night. And so what I just asked is a nomination for every week of 5 names of people who had been doing cool stuff that maybe I might not have had on my radar, because my days were all about meetings on vaccines and COVID and press conferences and all sorts of things. So I had collected 5 names a week, and I cold called employees, some of whom thought I was firing them. But it was really fun for me. And I spoke to a woman who, during Operations Allies Welcome, we had to deploy people in really rapid fashion to do medical screening. She was the one who stayed up all night to book their flights. And it was just like, you realize that there were logisticians in the agency, somebody who knocked on doors after the Ohio train derailment to see how people were doing across the whole community. So you just talk to all these different walks at the agency, and it was really incredible. I never expected that to have the ripple effect that it did. I thought 5 people a week, but it really did. People were excited when they got my call, and they sort of spoke to their divisions and their communities about thanking them globally for the work that they were doing.
And if I'm correct, you had actually 3 standing ovations as you were departing. So that is a remarkable turnaround. Not that there aren't still challenges. Maybe come back to that. Still lots of challenges. But that was a very you clearly touched a lot of people. Okay. Now look outside of the agency, right? Mm-hmm. And I think when we've had these previous conversations, you've emphasized how important it was within the agency. I want to talk about misinformation, but just even some of the things you were doing within the agency to just even take stuff down off of the website that was not science-based, emphasizing these principles of science. But when you're reaching outside, there are a lot of people that you need to speak to who don't actually value science in the way we value science, right? So in our hearts, and what we hold in esteem is evidence-based policymaking, right? And if the people are saying, well, the policy has to shift because we're getting new evidence, we're like watching, okay, clean the groceries, don't clean the groceries, double mask, one mask, what kind of mask, We're like listening in, we want to hear it, but there's a lot of people in the country who are actually hearing that as contradictory, this is shifting, can I trust these people? Can you talk about some of the things that you did to reach some of those folks who are outside of our bubble? Yeah,
so one of the first things that we had to do, and I asked Ann Schuckett to do this, was, so CDC has 200,000 web pages. And I asked her to comb the web pages that were specific to COVID and to make sure that the things that were posted were actually by our subject matter experts. Because, in fact, during the prior administration, not all was. So several were taken down because they weren't. Several were revised because they had been revised. So that was critically important, just to make sure that the things that have our logo on them were actually done by our subject matter experts. You had to be on Twitter. My husband will tell you that I'm not allowed to read Twitter at bedtime. But you had to be on Twitter because the whole administration was on Twitter. And that was where, if you didn't know that something was posted, then you were going to be behind the 8 ball when they called you and said, what are you doing about this tweet? And so when you were on, you could actually see what is being said. And I would call people all the time and say, and some people were doing it intentionally, and you were probably not going to reach those. But some people, you could just say, let's have a conversation about this, because I don't think you understand the full context of what happened or why we made that decision, or the complexity of downstream manifestations of what would happen if we made the opposite decision. Or, I'll give an example of wastewater. How come you didn't use wastewater for your screening or for your posting of community levels? Well, the answer is Alaska doesn't have wastewater. They're on septic systems. So we couldn't have a policy that a state can't use. So there were things that were out there that were not obvious to everybody.
Yeah.
So I would pick up the phone and call. Sometimes having a direct conversation, having them have my phone number so that before they tweeted something again, they'd say, I want to make sure I got this right. I certainly had a lot of conversations with people in the media and really worked, especially before we were rolling something out, to make sure that the media got it right. They were only going to necessarily have a couple of minutes to describe something, but I wanted to make sure that they had the information that they needed to get it right. And then, you know, part of my other audience is members of Congress. And so reaching across the aisle, not everybody wanted to hear from me, but, you know, there were certain congressmen, even across the aisle, where I would say, there's new vaccine data out. Let's go through the slides. I want you to make sure you understand why we made this policy, what those vaccine data show. And I had several people who were receptive to that.
So you and I talked a little bit about this before, also like how I also want to take you to where you went on the ground with folks, but in a moment. But your network, you kind of arrive with this scientists network, right?
Yes,
and then can we just talk about, like, actually, you're describing it implicitly, but talk a little bit more explicitly about, you know, how if you're going to play this leadership role, you realize you're going to have to create a different type of network around you.
So I'd never needed this kind of, you always need a network, right? But I never needed the network that I needed in the government before. So I'd never had it. So, you know, if you talk to anybody who'd been there, you can like find their Rolodex and they've got every member of Congress, and I had nobody. Yeah, I could find you an infectious disease doc really fast anywhere you went, but I did not have, you know, a lot of members of Congress or a lot of members of the media. Yeah, I just didn't have that role. Or even at HHS, you know, like many people at HHS were from the Obama administration and frequently used the term "the band's back together again," and I'd say, like, can I play? So it was really, I mean, you had to do it quickly, you had to develop trust fast, you had to do it remotely, and we're in Atlanta. Right? So we weren't even in DC to be able to have those conversations. I was on the Hill. I did 17 congressional testimonies. I was there for a couple of days before almost every time, trying to meet almost every member who would meet with me in their office to say, what are the things that you want to discuss? I want to be here as a reference and a resource for you. And that, when things then happened in their jurisdiction, when there were cruise ship issues, I could call, you know, the senator from Alaska, Senator Murkowski, and talk about issues related to cruise ship. Or when, you know, so you over time you develop those relationships. Gosh, it would have been so much easier if I had them when I walked in. The other place was state and local epidemiologists and state and local health departments. I early on I couldn't do everyone, I couldn't do one-on-ones, but I did it by region. I did all 10 of the regions, and I met all the state and local health departments, and much to my chief of staff chagrin, I think I gave them all my cell phone number. So that if there was a challenge or an outbreak or something, and they were not getting what they needed from the agency, they could call me, and I always returned those calls.
I wanted to give you one other example, which I thought was so interesting, was your realization also that, you know, they have you out giving these press briefings in the White House all the time. But then you sort of, over time, you started getting a more nuanced sense of the landscape also of journalists who are out there. Can you talk a little bit about that?
Yeah, I mean, there was a reasonable conversation around those press conferences, which we did 3 times a day from the day I started, 3 times a week from the day I started, Monday, Wednesday, and Friday for over a year, were under the White House backdrop. And it wasn't obvious to me. I was really a deer in headlights coming in, and I was just absorbing so much. It wasn't obvious to me that that was being perceived as political rather than health. And so it might have been the COVID czar and Tony Fauci and me and Vivek Murthy or whoever it was, but it was on the White House backdrop. I do think, even in retrospect, and I certainly didn't want to be perceived as political, but there was so much information that was so new and such an opportunity to split us in our messaging that it was really important that we all had the same message in the same moment. And the way to do that through the COVID response team was through the White House. The challenge there was that the people who go to the White House press conferences are political reporters. They're not health reporters. And everybody's got their level of expertise, but when we were trying to say something that was kind of health nuanced, we were actually talking sometimes to the wrong kind of reporter. And so I would really spend some time then trying to talk to health reporters to maybe unpack some of the details of what just went down.
So before I go to social media, I want to also talk about another constituent, which is like the folks on the ground. So not just folks who are kind of the leaders of the response or opinion leaders or thought leaders, but you also, spoke with workers in Georgia about the stigma associated, for instance, with being vaccinated and things like that. Can you talk about those conversations?
Yeah, so once I was able to get out a little bit more, and one of the first stops I made was in Northwest Georgia, Dalton, Georgia. That is Marjorie Taylor Greene's district. Wouldn't necessarily think that I would always be welcomed in that district. And we had a conversation and said, okay, everybody who really wanted a vaccine had been vaccinated at that period of time. And the question was, how do we reach people? And I'd done a lot of work in HIV, and I knew through my work in HIV, you have to listen. What are the challenges because every community is going to be different. What are the challenges? So we went to Dalton, Georgia, and we listened. And many of the workers there work in carpet factories. That's a lot of the work that they do there. And what they said is, it's stigmatizing. We can't go to church and say we want to get vaccinated. That was very stigmatizing at the time. Not everybody's community thought that was a good idea. But they were willing to be vaccinated. So the vaccinators actually went to change of shift at 4 in the morning at the factories. And they vaccinated people. And when they did, then the workers would come home and say, well, work made me do it. And then their partners might say, well, you seem to have done okay, and it wasn't so bad, or you didn't get sick, or, so now I'm going to get it too. And so that was a little bit, one of the ways we were able to do it. The other thing that we learned, which was so interesting, and this is why it's so important to go into community, we were having a hard time getting elder Hispanics vaccinated. And one of the things we really learned from the community there was there was such a digital and language divide that if we wanted to get the elderly Hispanic population and Latinx population vaccinated, we had to advertise to youth, which was not obvious. Some of them were not even eligible to be vaccinated yet, but we had to do that advertising to the youth so that they would go home and tell their parents and grandparents to go get vaccinated.
I'm going to go really micro for a minute because a couple of these deals are really interesting, but it was TikTok basically,
right? It was
right?
TikTok and Instagram.
So you had to get out there. And so that's also, how do you get advised on how to, I've gotten a little bit of feedback that our TikTok channel is a little staid, maybe out of culture. Did you get advice on how to
I
appear?
didn't necessarily do all the TikTok.
Okay.
I did a few Instagram hijacks and things like that they do. Is that not even what they're called? But takeovers.
Freudian hijack, yeah.
I've done a few of those, but I wasn't necessarily the one doing all the social media, but I was learning about how we needed to do it and who we needed to reach. I'm not sure that my being on TikTok would have done the trick anyway.
We've been working a lot on kind of micro level things about how to have conversations and how to listen. And when you were speaking, you were talking about advice that a fellow had given you about how to listen when you're telling somebody. I'll just let you tell the story because you tell it very well.
So when I was a first-year infectious disease fellow, we still had quite a bit of new HIV diagnoses. And so I had done this a lot during residency because we had so many new HIV diagnoses during residency, but she was a social worker, actually. Susan Layarby, she's awesome. And she said, this is how you give an HIV diagnosis. You tell somebody that they have HIV infection, and then you stop, and you say nothing else. And that is really hard because it can be a very long time. But the important thing, you don't know what is going to be important to them in that moment. What is their biggest fear, what they are concerned about. And you could talk for a very long time and actually not reach it. So you really do need to listen first. Is it, I can't afford my meds, where did I get this? Am I gonna lose my job? Am I going to die? Is my baby sick? You know, all of these things, and you really don't know what their concern is. So you have to wait for what they say next. So much of that is actually true in, you know, when people say, how do you convince somebody to get vaccinated? The answer is you listen. I met with one congressperson who told me that she had actually gotten Guillain-Barré from a flu vaccine. If I was trying to convince her to get vaccinated, that would not be where I would go, right? I would talk about all of the benefits of the COVID vaccine and all of the data and all of the safety, and I would have never touched her biggest concern. So it really is important to listen.
Yeah, critically. It's a very poignant, it's just such a poignant story. I think all of us have so much to learn from that. Wait, not to presume we understand what it is on people's minds. I want to go back to another place where you have described pulling on your values as a doctor, and that was in making decisions at certain points where, you know, the data weren't out yet, but you could see, you had the access to see where it was headed. And there were real questions, I mean, real debates to be had, you know, politically as well as, you know, ethically from a medical perspective. Do you wait until everything is totally buttoned up so that you can defend yourself in the press? Or do you go out early because, you know, it could save lives? And could you just tell, you know, some examples of this where you were...
Yeah, they're painful. I mean, partially because you know that there's no right answer, which means there's no wrong answer, right, of course. But the challenge always was you knew you were going to take heat either way. And so the example that's most poignant here was July of 2021. We had the new Delta variant. That new Delta variant had demonstrated through Barnstable County here in Massachusetts, that if you were vaccinated, you could still give the virus to somebody else. That was not true in the Alpha variant, it was true in Delta. But ultimately what it meant is if you were vaccinated, we had to put masks back on. It was a kick in the stomach on a Friday night when I saw those data. It was an LGBTQ community where we saw it first. It was critically important to me that not be quote unquote blamed on that LGBT community. So we really needed to be careful there. It had been corroborated. We had seen data in Texas in a correctional facility. We then actually called the UK, asked if they were seeing it as well. So this all happened over a 12-hour period of time. But it became very clear that this was not just in one study. It had been seen over and over again. So then the question was, okay, do we put masks back on now? Or do we wait until all of these data have like their I's dotted and T's crossed and ready to be published? And if we went out before the data, then people would say, well, show us the data. And if we waited, then people would say, you knew this 2 weeks ago. How come you didn't do anything? And so in that moment, I put on my doctor hat and I said, I'd want to know if you know, my immunocompromised patients would want to know. And so we made the decision based on, you know, what I think was the right thing to do. And yes, I remember the Stat News reporter calling me and saying, how could you do this? You haven't shown us the data. And I said, it's coming. And we reported it, you know, 5 days later. It's the fastest we'd ever gotten a piece out.
Very powerful.
Yeah.
Okay, and I'm going to read from my notes because there's an IOP formality, but I'm giving you a warning that I'm going to start calling questions soon. So we have 4 mics. We have mics here on the floor on these calendars, and we've got 2 up there, and I think they call it the loge area, but basically the stairs. So in just a couple minutes, I'm going to open things up to the floor. When you ask your question, please be a question. That's really important. Identify yourself, ask a question. The question should relate to the speaker. Pretty straightforward. We have enormous political potential in, I'm sure, the audience here and in the school certainly, but not speeches, questions. Questions for our speaker, and we're really eager to hear them. I'm going to ask one final question now, and then we're going to open it up to you all, so please head for the mic if you want to ask a question. So the question I want to pivot to, we've been talking about service inside of government, but you have also contributed meaningfully from the outside in through your research and your engagement with policymakers, and you had a big win lately, and so I would love for you to talk a bit about that, because that is also very meaningful work. Yeah.
So a lot of my work in HIV has always been to understand where a policy either doesn't make sense or whether we need to move or motivate a policy, and to provide some science behind it. So one of the more recent bees in my bonnet, as my colleagues like to call it, was that we had not updated our blood donation policy for the LGBTQ community, for men who have sex with men, since like the 80s. At the time, it was very hard to move the policy to restrict.
Actually, maybe explain for our audience what was the policy.
Okay, so sorry, thank you. So the policy had been in the 80s to restrict blood donation from the LGBT community because of the risk of HIV. That was actually hard to implement, and probably implemented way too late. And in fact, I think the data actually show that because of the risk of stigmatization at the time, that didn't happen fast enough, and there were a lot of HIV infections that occurred. Since that time, we have better tests, we have better screening, we have better treatment. So much has changed, and the LGBTQ community has not been able to donate blood, and this really came to a head after the Orlando mass shooting, where so many people from that community wanted to give blood in response to that shooting and could not.
At a gay
nightclub in Orlando. And so we had written and done the science and sort of demonstrated that was an outdated policy, that we were restricting blood donation inappropriately, and in fact, we actually had better screening tools now to restrict donation for the people who are at high risk, but that all LGBTQ were not at high risk. And so we wrote about that in 2017, and one of the real gifts of being in the government is that then you can actually do something. And so it happened, the stars were aligned. The Assistant Secretary of Health, Dr. Rachel Levine, was also interested in this. The FDA was making progress here, and my senior policy advisor, who's now our state health official, Robbie Goldstein, we were all together able to move this forward, and that policy just changed at the end of May. And Dr. Goldstein and he was unable to donate blood ever, and he and I donated blood together for the first time on August 9th, 29th.
Fabulous. All right, we're moving to our questions. Please step forward again. Please introduce yourself and pose your question.
Hi, thank you so much for your time. My name is Hannah Friedman, and I conduct research for Boston Children's Hospital in their endocrinology division. I had a question for you. In the age of polarization and misinformation and disinformation that's impeding public health and the safety of people, do you find it beneficial to separate the nomination of the CDC director away from politics? If not, do you have any other suggestions on how to convince the public that the CDC is solely focused on science and not influenced by politics?
Thank you for that question. So one of the things that I think was unique about my position when I came in is I was not a Senate confirmed position. So I was sworn in an hour after the president. I have reminded people that I testified in Congress, I believe, 7 times before the FDA commissioner was actually Senate confirmed, about a year later. So I think it was critically important during the pandemic that there be somebody who was able to jump in and actually do the work. The Senate confirmation has since changed. next CDC director in the next administration will require Senate confirmation. I personally believe that certainly in this very polarized situation that we find ourselves in right now, that actually will lead to more challenges than help. It took, our new NIH director was just confirmed yesterday, but we have been without an NIH director for 2 years. And certainly I think when we have really challenging health times, we need to really hit the ground running. Some have proposed, and I haven't thought this through fully, but I think that this is one good option, is to say every 6 years we have a CDC director that is nominated by whoever the president is at the time, so that that person may have to bridge administrations, but then will be so focused on doing the right thing for health.
Okay, I'm going to go clockwise.
Hi, thank you so much for being here. My name is Alex. I am a senior at the college. I have a question about kind of the polarization of public health policy. During the pandemic, we saw Republican states kind of shy away from mask mandates and vaccine mandates, and Democratic states implement more of those policies. There was even a divide in vaccination rates between Trump voting counties in 2020 and Biden voting counties in 2020. So I'm curious to try to see, like, what do you think contributed to this problem of the politicization of public health policy, and what you think the CDC can do to try to reverse that?
I know the CDC is working hard on that. What I will say from a vaccine policy and a vaccine administration standpoint, there's now been documented evidence of increased deaths in places that had lower vaccination rates. And then when they divide them by red and blue counties, or people that have voted red and blue, you see that divide. When you correct it for vaccination rate, that divide goes away. So it really is people who are working to undermine vaccination. All of that, having been said, and I think that this is really important, is that one of the real lessons that I learned in the last 2.5 years in dealing with health and the health challenges that we've had is that health is but one seat at the table. In my mind, it is a really important seat at the table, but we also have to recognize that it is not everybody's most important seat at the table, and where you come from really matters here. So not my favorite topic, but I will raise school guidance. People have different opinions about how risky they are willing to be in having their kid back to school. If you have a very immunocompromised child, or somebody who's very immunocompromised in a household, health is a really important parameter. If you have a kid who is only going to college if they get a sports scholarship, then you need that school open to play those sports, because if they don't, your kid's not going to college. And it starts opening your eyes to some of the really important things that people are considering, food security or housing security related to some of these policies. And so I do think it's really important that we hear all of those voices as we're making these decisions, and not to just say health is the only important thing.
Hi, Dr. Walensky up here. Thank you so much for your talk and for your service to our country. My name is Kelsey Hayes, and I'm a Master's of Public Administration student here. So my question is more of a leadership one. So curious to hear more about your decision to resign when you did, and specifically as a leader, how do you know when it's time to go? And what kind of systems do you think about setting in place to make sure that transition is successful?
Thank you for that question. So, here, I sort of went into I did go into the administration saying I had to get us out of 3,000 deaths a day. We had to get out of COVID. And we did that. We also tackled a huge number of infectious threats along the way. We had 63 foodborne outbreaks in 2021. We had Ebola. We had 2 outbreaks of Marburg, which is a cousin of Ebola. We had paralytic polio in this country for the first time. We had Mpox. Who would have thought we were going to have an Mpox outbreak? So it really was kind of reigning infectious diseases. The other thing that we did, and Dr. Nana mentioned this, was we did this initiative of moving forward, and the really hard leadership work, I think, of putting a mirror up to an agency that had been beaten down and said, you did amazing stuff. We got 670 million vaccines in arms in 2.5 years. And we may face another pandemic soon, and we need to figure out how we can do better the next time, and what did we do that we need to do better. And so having started that initiative and recognizing that that work was going to be long work, it was not going to, however long my term, that was not going to be, I was not going to be able to accomplish all of those things, but to set forward the agenda of what the agency needed to do moving forward, I think was really critically important. I am an action-oriented doer, and so I wanted to do a lot, and we did a lot at that agency, and I thought it was after having launched that it was time to pass the baton.
Thank you for being here, Dr. Walensky. My name is Justin Smith. I'm a Doctor of Public Health student here at the school and former CDCer, so thank you for your leadership. My question is, as you look to the future of the field of public health, what do you think needs to be added or changed to the curriculum in schools of public health so that we create the public health workforce that's best able to meet the next pandemic threat that we face?
Yeah, that's a great question, and I've thought a lot about this. So first of all, we need upskilled data systems. Our folks in state and local public health departments are not as upskilled as they need to be, and they've told us that across the country in terms of data analytics, AI is coming, digital, cross-data, health IT, communications. My communications director at the agency position had been empty for 4 years when I got there. So yes, 3 press conferences a week without a communications director. So I mean, I had 4 acting people in the role, all of whom were wonderful, but that lack of stability, and I think it was really important, especially in these times, especially in mis and disinformation, what we need to do. And then I do also think that our schools of public health are not as good, at least some of the ones that I know of, in applied public health. They're really good at teaching methods and epidemiology and plans for research, but are there opportunities to work in a state and local health department to really understand what it's like on the ground?
Hi, Hi. Thanks for being here. I'm Dick Toffel. I'm a visiting fellow teaching at the Chan School. 2 questions which I think are related. One is, in light of our experience with the pandemic, do you think the nation's public health bureaucracies need to be reorganized? And second, do you think, in retrospect, that we made a mistake in not appointing an official commission to investigate what happened in the pandemic?
I think our public health infrastructure, I'm not sure that we need a reorganization. I think we need a less frail infrastructure. When you think about the fact that CDC is the federal agency that runs this, but it is only as successful as its effector arms in state and local health departments, and you recognize how underinvested our state and local health departments are. The fact that I was getting data by fax machine, that is unreal. And in fact, some people would joke, well, we can't use the fax machine that was bought on the sickle cell grant because this is COVID. I wish I were kidding. So like that is the infrastructure we're talking about in some of these state and local health departments. 80,000 public health workforce in deficit across the country. So we can talk about the best way to organize it, but the bottom line is we don't have the infrastructure that we need in order to do it well. I'm agnostic. There have been a lot of people who have written reviews on, and there will be many more to come, I'm sure, on whether there was a commission. Many people will be talking about this. I'm agnostic as to whether we need another one, because I know many people had reviewed. We had done our own review, and the CSIS did a review, and Commonwealth Fund, many people had been doing these reviews of CDC, and I think that there will be more to come. But I do think, and the quote from earlier that said, it is so, I mean, we're back to life as usual, which is great. That was the whole point. But the Defense Department for a pandemic is HHS, and we don't have the budget that the Defense Department enjoys to bolster our infrastructure to get where we need to be after 1.2 million people died in this country.
Thank you, Dr. Walensky. I'm Aiden Taylor, a second year at the college. After your departure, the Associated Press said that two of the reasons were exhaustion and success. I definitely agree with success. And I think most individuals at the local and state health departments, including at the federal level, would agree that public health work is exhausting. How do you, and you also mentioned the deficit of public health workers, how do you think that we, as an education system and as a public health and government systems, combat that exhaustion that definitely exists?
Yeah, I've gotten some sleep. Here's what I will say is, I vividly remember those early days of COVID, and you saw the footage on the screens of people cheering for their healthcare workers and their public health workers. And you know, that doesn't happen very often. We don't need that very often. It's not like we need cheers all the time. But somehow, over months, it pivoted to attacks and vitriol and threats. And people go into this service and into public health and healthcare knowing that they're going to work out long hours, knowing that they're going to be other oriented. And you do that because there's like, you do it for the right reasons. You do it because people matter. You do it because, because there's gratitude, even you like what you're doing because you're doing it to benefit others. And when that goes away, I think that that's a real challenge. So I do think we really need to, there is work that we need to do to bolster the infrastructure. There's human resources, authorities that I specifically asked Congress for at CDC, overtime pay, or how about hazard pay? How about when I send a CDC employee into Mubende, Uganda in the middle of a Sudan Ebola outbreak, that maybe they get hazard pay. They don't right now. And so like those kinds of things I think would go a really long way in sort of recognizing, so much work in leadership is about recognizing you're feeling valued. And I think that public health and healthcare over the latter parts did not feel valued. I don't think you can work that hard for that long without feeling valued.
Hi, my name is John Mulhern. I'm a docent at the John F. Kennedy Presidential Library and Museum. My question to you is, do you see a differentiation between the public's right to know during a healthcare crisis like the pandemic, as opposed to the public's desire or want to know? That's my question.
Well, that's an interesting question. I did everything I could to tell people what we knew when we knew it. Certainly as we were trying to make policy and as we were trying to understand, like when we didn't really understand the implications, we weren't really ready to say anything. But so much of what we've learned is you have to tell people what you know, tell people what you're doing and what they can do, and then tell people what you don't know and what you will update them on when you learn it, and then always the final edict is, and this is all going to change. Yeah. And so I think that we did our best. I did my best to let people know what we knew when we knew it, and that was again back to the mask situation. That's why I felt it was so critically important to say it at the time.
One last question, and then I get to have one too.
Thank you for being here today, Dr. Walensky. I'm Camille Price. I'm a first-year Master's in Public Policy student here at the Kennedy School. During COVID, I worked across 3 state health departments working on cold chain capacity and predictive demand modeling, and then finally vaccine hesitancy in a very hesitant state. And one of the challenges that we struggled with most was just the lack of reliable data and understanding where people were, if they'd been vaccinated, how hesitant they were, what their comorbidities were. I wondered if you could speak to how the CDC is thinking about, the concept of a universal health database and what it would take to build that and under whose purview that really sits in the government.
Oh, yes. Here's what I will say is, as you can imagine from where I was standing, when I knew data existed and were out there that would help me make a better decision, and yet I didn't have it, that was just so frustrating because I really so badly wanted good data. One of the examples that I will give is, we were criticized a lot for having all of our vaccine effectiveness data come out of Israel and the UK. Why did they always do it first? Well, if your health system has hospitalization data and your public health system has vaccine data, vaccination data, and they don't talk to each other, you have no way of doing that. And so there's active efforts right now through CDC data modernization efforts to try and have our data highways connect. Now that's not easy. We have 3,300 county health departments. We have 50 state health departments, 9 city health departments, 5 territorial health departments, and 574 tribes. And they all send CDC data. And we have this whole healthcare system. So we're working on modernizing the data highways across all of those departments of public health. But then we also have the clinical systems. And Mickey Tripathi at ONC and HHS are really working to get Cerner to talk to Epic, to have all of those systems talk to one another with the grand plan to have the public health and healthcare systems come together. Budgets are a challenge, data authorities are a challenge. Just to give you a sense, CDC has received about $1 billion for our data modernization initiative. That sounds like a lot, but single hospitals have cost $1 billion to put in Epic. So it is nowhere near enough for what the country needs. And so, spent a lot of time in Congress talking about that as well. So yes, we have work that we need to do. CDC knows it and has been challenged by not having the data that they need, and they're actively working on it.
I think there was one question over here. Somebody had been waiting. Oh, please go ahead, and then we'll close. We'll give you the last question.
It's not quick. My name is Marcy Sims, and I'm an Advanced Leadership Fellow and on the board of the Women's Politics and Public Policy. And thank you for your service. If there were no budgetary constraints and if you had a magic wand, what would effective healthcare look like in America? Because you keep hearing that the system's broken. So what does an unbroke system look like?
Oh, wow. Well, there's healthcare and there's public health. I think we need an army or many, many more people. First of all, I think we need people who are invested in doing the work of healthcare, primary care, geriatric care, family medicine, the things that are, people who leave medical school with $250,000 in debt are not necessarily going into. That is very true in healthcare as well as public health, and that we need a robust workforce to be able to do that. But if a primary care doc is making a quarter of what a cardiologist is making, they're going to, and they come out of medical school with $250,000 in debt. That has to be fixed for people to enter the right specialties. And then we need that in public health as well. The data systems, everybody's talking about AI as all the buzz. I'm still talking about fax machines. So we do need to be in a place where when AI is being delivered at our doorsteps, that we're ready to receive it and use it for good and health, because there are many people who are out there looking for ways that can be used for mis and disinformation, and we have to be ready for that.
So great. It is always so great talking with you. It's really wonderful. I want to close this out, and I shared this with you ahead of time, and you said, oh, I know this only too well, but I want to read this. So I was preparing for this interview, and I was reminded we've just celebrated David Gergen, whose name you might recognize, advisor to multiple US presidents, regular commentator on CNN. He's just retired from our faculty in our Center for Public Leadership, and kind of in his finale, he wrote this book, Hearts Touched with Fire, which was about trying to inspire the next generation to head into public service. And in the book, he pulls on this passage from a speech by Theodore Roosevelt, who had just, it was about a year after stepping out of the US presidency. And I want to read you, I'm going to shorten the passage a bit, but I'd like to read it because it reminds me of the extraordinary service that you did. And I want to ask by saying, how do we call people to this extraordinarily important but difficult work? And so here is this quote that from Theodore Roosevelt that David Gergen always elevates. "It is not the critic who counts. The credit belongs to the person who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, comes up short again and again, because there is no effort without error and shortcoming, who at best knows in the end the triumph of high achievement, and who at worst, if they fail, at least fails while daring greatly." Just one word.
Because somebody had reminded me of that, and there were a lot of people who were critics, and so I did have to frequently remind myself that it was not about the critics, and that I was in the arena, and I was going to do the best that I could while I was there. And I will just say, I never thought I would get the phone call that I got. I never applied for the job that I took, but I spent some time talking to Robbie Goldstein, my senior policy advisor, some really dark days and some really dark nights. Like, why are we doing this? Like, are we making a difference? Are we really making a difference? And, you know, he would remind me, we get to do what we think is the right thing to do in the moment. And that day that the policy changed for blood donation, he texted me and said, "We made a difference." And so you do get to make a difference, and it is hard work, and it is lonely work, and it is not always fun work, but it is mission driven, and it is for the right reasons, and we need all of you, and so that is why you do it.
You do need to. Thank you so very, very much. Thank you so very, very much. That was beautiful.